part 2. I want to talk about field pronouncement, which is not exactly synonymous with termination resuscitation, but pretty close. The terms are used pretty much interchangeably these days, and PCPs right across the province are doing tours, so you guys are well familiar with tours, but I'll talk about some things that may be new to you, may be different from the region where you work, particularly on a means of identifying the decedent. So we'll talk about pronouncement, post-pronouncement, giving verbal reports to the coroner, identification, documentation. Caring for the family will be a separate talk next week, and when do police attend, and then address some FAQs. And this is a presentation I initially put together back in around 2000 when I was base hospital program manager in Peel region, and we were getting ACPs for the first time in that area, and they were going to be doing pronouncements. PCPs weren't doing pronouncements at that time, and it's interesting because the base hospital docs, a lot of them objected to paramedics doing field pronouncements. They didn't feel comfortable with that at all. They didn't feel comfortable patching and giving a pronouncement. And so times have changed, that's for sure. So in terms of assessment, we do the usual, obviously, ABCs, heart sounds, monitor, unless they're code 5, of course, and neuro assessment. We want to gather relevant history, medical history, HPI, meds, allergies. Some of the critically important information are things like, was this a witness or unwitnessed arrest, and if it was witnessed, was CPR done by witnesses? What time was it witnessed? What was the approximate time of the arrest? How long has CPR been going on? Because when you contact a base hospital physician, as you guys already know, because I'm sure you've both done tours, what the BHP wants to know is, when was the arrest? How long has CPR been going on for? Those are the two critical things. So was there a time lapse between cardiac arrest and when CPR was initiated? Resuscitations are broken down into code 5s, which I'm not going to talk about, but futile resuscitations, we'll start with there. That's probably the most common one that you and I encounter. And so we initiate or we continue CPR, we switch to our monitor if fire's already got them on our monitor. We might DC CPR briefly to confirm the patient's VSA and interpret the rhythms. It just depends on where they are in the cycle of things, or we may just hook up our pads while chest compressions are still going on. And we continue CPR, we get IV access, we give meds. Intubation sort of falls later down the line, generally after 3 rounds of meds have been given, and we administer rhythm appropriate drugs, plus or minus fluids if they're PEA and suspected hypovolemia. And the research has shown that we need to run an arrest for minimum 35 minutes on scene, so that's the sort of cutoff line. And there's no point in transporting before then, because CPR quality just goes downhill and dramatically reduces the chance of having a return to spontaneous circulation. And beyond that, we would patch if this, in your opinion, appears to be a futile resuscitation. We patch to base hospital pronouncement, and those are generally non-shockable rhythms. There's a view of many physicians that if the patient's in a shockable rhythm throughout the arrest, that we transport no matter what. So 35 minutes from the point of EMS contact, Harry, would be, but obviously if it's been, let's say, 20 minutes before we arrived and no CPR was done, that changes things pretty dramatically. So yeah, it's I'll see if I can find the research paper on that and pass it along. So ALS procedures should have all been instituted, and there should be a non-perfusing rhythm for at least 35 minutes. The patient should be adequately ventilated, preferably intubated, appropriate drug regimen, that means at least 3 rounds of epi and any antiarrhythmics that would be appropriate. And there's no known reversible cause of the terminal rhythm. And I put a star here next to that because, again, if you have a patient in a shockable rhythm, a VF or pulsus VT, we generally transport those patients no matter what and continue attempted resuscitation. So policies may vary from base hospital to base hospital, but this is based on the base hospital policies in Southern Ontario. So resuscitation may not be appropriate if there's a clear history of downtime greater than 30 minutes. And we perform a complete assessment. We confirm asystole and 2 leads, patch to base hospital for pronouncement. So this perhaps addresses your concern, Terry, about the long downtime of 30 minutes or more. And generally speaking, if we arrive and CPR is still in progress and the patient is in, we determine that the downtime's been greater than 30 minutes, and we confirm the patient's in asystole and 2 leads, I would patch the base hospital and let them know. Terminally ill patients, so where a legally executed DNR exists, then we can discontinue, and there has to be some sort of reasonable facsimile of that. So it has to be something in writing, nursing notes or advanced directives or something like that. They're a little less stringent about the type of document than they used to be in the past, at least under the base hospital where I work. And so we do the usual assessment, confirm asystole and 2 leads, patch for pronouncement in those cases. If there isn't a legal document, I would still patch early, particularly if it's the wish of the family that resuscitation not occur. So what about transportation of a patient who's been pronounced? Number 1, I would say don't do it. Don't ever do it. If you initiate transport, just don't call for a pronouncement. Take them to the ER and let the ER pronounce them, because if you pronounce them in the back of the ambulance, you're going to be out of service for a long, long time, and it's going to be a veritable nightmare for you. Do you know of anyone who's pronounced a patient en route to the hospital? Or have either of you done it?
We do it quite frequently in Sudbury. If we pronounce on scene without initiating transport and the patient's in the truck, then we're stuck there for a significant amount of time waiting for the coroner. If we're already transporting, and we call for that tour, they'll allow us to continue to transport to the hospital, non-emergency, and they'll deal with it there.
So you guys probably have a system that's nicely worked out. In some of the urban areas, the shorter transport areas, this is not something medics do routinely, and as a consequence, the hospitals get very confused as to what to do, and there ends up being extreme delays on the scene. So I'm assuming you guys have a pretty well worked out system.
Back when I was a student in Peel, I remember we pronounced the patient in the ambulance, but what ended up happening is the hospital actually took the patient and put them in their recess room and left them there. So I'm not sure how that exactly. I was sure about the details of the that were going on in the background because I was a student.
Yeah, you can't really do that. That might have been a one-off. What happened?
It must have been.
Yeah, that decedent has to go to a temporary morgue, and you have to go through the admitting office, and the coroner has to be called, and you still have to stick around. So it's not quite that clear. The crew might have just gotten lucky when you were a student, from the sounds of it. So Roger, you were about to say something?
Yeah, only just pretty well the same as what happened to Terry there. It's just that we'll generally bring them. Oftentimes we'll end up taking the patient to our decon room.
Yeah.
And then the coroner is going to come in and assess the patient there.
Yeah.
Normally the crew doesn't have to remain on scene though. Yeah. Should the hospital's aware of what crew brought the patient in, and should the coroner have any questions for the crew, either they can come back to the hospital or whatever the case may be.
Yeah. So and I think that system can work if it's done on a regular basis and hospitals know what to expect. I'll tell you how it's supposed to work. So first of all, there are 3 circumstances where this might happen. One, you're directed to do so by the coroner, which is unusual to transport a decedent according to the coroner. Usually that's because it's in a public place, or if a pronouncement occurs en route to the hospital, or the remains are in a public place and it's in public's interest to remove the body at discretion of the coroner or the CAC center. And so the procedure is supposed to be, you notify CAC that the patient's been pronounced, leave all tubes in place, just as you would for any tour on scene. The attending ACP notifies the coroner of the field pronouncement and the location of the deceased is to be transported to. You apply a wristband to the deceased as per policy, at least that's our policy. And then at the receiving facility, the driver remains with the deceased while the attending medic goes in, registers the patient. With registration, provides essential information as well as the name of the coroner assigned to the case. And registration is supposed to contact to accompany the crew to the morgue. Registration is also supposed to contact the crisis team because usually the family follows and arrive in hospital. And the crew takes the patient to the morgue as directed by security or registration. Complete all documentation if it's paper documentation, and the white copies left for the ACR for the coroners. But generally speaking, the decedent should not go through the ER unless you absolutely have to. But if that's the system that works in your area, Roger, or Terry, I know it doesn't work that way in Peel. That might have been just a one-off because I helped write this policy years ago for Peel. So at least that's not the way it's supposed to happen.
Same with York. Yeah, York, you don't do that.
Sorry, it was York? Not Peel?
Same with York, we don't do that.
Yeah, okay. So, yeah, I mean, I've never pronounced a patient in the back of the ambulance. I just wouldn't do that. But if you're dealing with long transport times, that's an entirely different story. So some contraindications to field pronouncement situations where resuscitation should be continued include hypothermia or hypothermia secondary to drowning, pediatric patients 0 to 15 unless the DNR exists, high voltage electrical shocks, overdose patients, and then anyone of a number of other unusual situations, unusual circumstances. So the pronouncement procedure or TOR procedure, so if you've received a TOR or a field pronouncement, we advise everyone involved to discontinue CPR. The body is supposed to be left in place. So generally, if I run a resuscitation and I think I'm going to get a pronouncement in advance, I will avoid putting the patient on the stretcher because technically we're not supposed to take the patient off the stretcher until we call the coroner and get permission to do that. We leave all tubes in place, endotracheal tubes, IV lines. We just shut IV lines down, disconnect the BVM. We don't need to lead the BVM. When I say speak to the family, again, that means that, at some point before, the fourth round of drugs or so, someone should have stepped out to speak to the family to give them the news that the prognosis doesn't look good and, sort of explain what's happening and what we anticipate is happening so that when we go to see them again, it's not too much of a shock. Contact the coroner now. This varies from place to place. Where I work, sometimes we contact the coroner, sometimes the police contact the coroner. I usually say to police, are you going to contact the coroner or do you want me to speak to the coroner? And so they're used to us doing it. And the coroner likes to speak to paramedics because they get a medical report, not a police report. And we have an identification system now. Do you guys have an identification system in Sudbury and in York? Roger, let's start with you.
An identification in what way? Like to identify ourselves? Or to
No, to the patient. Do you have a wristband that you carry with you for field pronouncements that you put on the patient? And
Oh, no, not that I'm aware of.
okay.
However, we are leaving documentation with the patient,
Okay.
and then if we're leaving the patient in the field, we're almost always leaving the patient in the care of police.
Police, yeah. And Terry, what about you?
So we used to have the red wristband.
Yeah.
But they asked us to stop putting it on, and we obviously have to leave the patient with somebody, either police or family. So yeah, no more.
Okay. Okay. So now, when it comes to documentation, we have electronic PCRs, and the coroner can subpoena the documentation. So that means that whether you're doing paper or whether you're doing electronic, they contact the supervisor. The supervisor immediately takes you out of service until the paperwork is completed. That's never happened to me personally, but I know medics for whom that has happened, and they've been taken out of service and finish their paperwork and then submitted it. Electronically, we have an option to submit it to the coroner, which is a nice feature. So we do that, and verbal report to the coroner should include the usual information, so age, gender, the history of presenting incidents, including the time of arrest, witnessed or not, assessment findings, including initial and final ECGs, care provided, including drugs and procedures, medical history, meds and allergies, base hospital name and the time of pronouncement, and the ambulance call report ID, which should be available. You just contact your dispatcher to get that if you don't already have it. Name and badge number of the attending police officer. Just out of curiosity, have either of you given a report to a coroner before?
I have once or twice, just in the event of a DNR where we weren't able to contact the patient's physician.
Oh, yeah.
So I had to go through the coroner.
Oh, okay. And what is the coroner?
Yeah.
So, would you not go through the base hospital if you weren't able to get a hold of the patient's physician?
Not in the case of our valid DNRs or our expected deaths.
Oh, okay.
I don't know what the reasoning is, other than maybe the base hospital just doesn't want to deal with something expected in this situation.
Yeah, okay, understood.
And so then we're really just asking the permission to release the body to the family.
Yeah.
And then we stick around a little bit, start helping the family make whatever arrangements that they may or may not have already had in place, and go from there.
Yeah, and Terry?
So it was a similar circumstance where we had to release the patient's body to the family, and it was a 90-something-year-old expected death.
Yeah.
And the coroner wanted a pretty extensive report just before that. I think it just the particular coroner liked it that way.
Yeah.
So.
Oh, cool.
Yeah.
Very good. Yeah, I like chatting with the coroner. I really think it's a paramedic role, not a police role. But either or. I always offer anyway. So if you do use a wristband system, if either of you happen to move to a service that does use a wristband service, the information required is the date, the decedent's full name, the date of birth, coroner's name, if applicable, the paramedic's region and OASIS number, and then a signature. So it should look something like this. This is what we use. Documentation. So we fill out all administrative fields, the patient demographics, the history, the usual stuff, basically the entire thing. ECG strips. I know with the PEEL system, they have to actually electronically attach the ECG, not something that we do with our Zoll series. And base hospital name, time of pronouncement of the TOR, the patch number, and name of the coroner, time of the coroner was contacted, name, badge number of attending police involved, and that's about it, really. Do you guys have any questions or further comments about TORs or pronouncements?
So I have a question.
Yeah.
We had an interesting situation. This was years ago. I was the second crew in. I was with the ALS, and the first BCP crew arrived to a patient that was VSA. It was a patient it was obviously a bedridden patient, palliative care, but he didn't have a DNR.
Yeah.
And what happened was, this was before a medical tour. So what happened was they initiated CPR against that was not the patient's wishes, and the patient's wife was there, and she was quite upset. And it was a little bit of a gong show, because when we came in, the patient was the family member was walking around and basically being very rude, almost belligerent to the fire trying to perform CPR, and she obviously didn't want this. However, the family member would not release the patient's medications. and would not give us any history for us to terminate the resuscitation.
Oh.
So what my question is, in that circumstance, which is pretty much we're being almost obstructed CPR,
Yeah.
can we call for a pronouncement in this circumstance where it is palliative, where it is against the wishes, and based on being obstructed, to have CPR done by the family member?
So, I've had a couple of situations like that, not where a family members refused to give us information. I guess, the question in my mind would be, why is she refusing us to give that information? Is she refusing to give it because she thinks it's going to encourage us to continue resuscitating, or just because she doesn't like us being there, or what have you? But
I'm assuming he knows, or she was just so upset.
yeah, well, I mean, what I do under those circumstances, because we have to do CPR, is I patch immediately to the base hospital doc. CPR only. I patch. I get information from my partner about what kind of rhythm the patient's in, presumably a systole or PEA, and I explain the circumstance to the doc and get an immediate order to discontinue resuscitation. The other thing I did once was we had a patient with amyotrophic lateralizing sclerosis, ALS, and the family didn't want us to do CPR, and we arrived, and before we got to his bedroom, I said, "Do you have a written do not resuscitate order?" She said, "We were looking for it, we can't find it." And I said, "Well, we're kind of compelled to do to start a resuscitation, and I can call quickly to my base hospital doc to get an order to pronouncement, but we're sort of obligated to do this." And she said, "I don't want you to do it." And I said, "Okay, well, are you going to physically stop me from going into that room?" And she said, "Yes." And I said, "Okay." So I called the base hospital doc at that point. I said, "Listen, I'm going to call a physician and explain the circumstances." And he said, "Okay, Rob, well, listen, talk to her and tell her, you're not going to do CPR. You're just going to go in and feel for a pulse and hook him up to the monitor to see, confirm that he is, in fact, vital signs absent, and I'll stay on the phone with you and I'll give you a pronouncement then." So I explained that to her, and she said, "Okay, let's go," and we did that, and that was that. That worked out well in that circumstance. But yeah, it's a terrible, terrible thing when someone
For sure.
doesn't want to resuscitate. I had another case of a lady who had a DNR, but the daughter couldn't find it. And the fire was already there before us, and they initiated CPR, and I apologized, and I elected at that time to start an IV and give her a round of epi. And when we did that, she went into VF, and I shocked her once, and we got her back. And it was kind of a bittersweet thing, because she was extubated, and she was alive and awake for about 4 hours in the ER. And then died, and they didn't resuscitate her. But I guess her daughter got to say a few more things to her before she passed again. But it was just, pronouncements can be a crazy thing. The other thing I want to say about pronouncements, and I haven't had this experience. I mean, I've had family members who are quite upset, but one of my past students was telling me about a family that were really hysterical, and the son was so angry and upset about this whole thing. I don't know if he was angry at himself or what, but he went upstairs and he ran, he walked to the end of the hallway, and then he turned around and ran back to the end of the hallway and dove off the top of the stairs and into the wall, put his head into the wall, right through the drywall and into the brick, and knocked himself unconscious. Had a massive head injury. I don't know if he died, but it was like a massive, massive head injury. And so they had to call in a second crew to resuscitate him and transport him. So I guess my message is, we have to keep a close eye on everyone around and their affect, and anyone who looks really agitated or quiet, we got to step in and intervene and talk with them to reduce the risk of anyone doing something irrational, for lack of a better word. So, anyway,
We actually had a family member assault the medic.
yeah, that's happened to me too.
BSA.
That's happened to me too. Yeah, it's crazy. We resuscitated this lady at the bottom of the stairs, and her son put me into a headlock. It was just me and my partner, and it wasn't hurting me or anything, but yeah, people do some irrational things. This assault, the medic wasn't hurt, was he or she?
They were off for a bit. They couldn't press any charges because it was considered an extreme emotional.
Yeah.
So yeah.
Right. Wow.
Yeah.
Nasty.
Yeah.
Okay. Well, listen. That's it for this morning, guys. I think we have one more presentation, maybe two more before the end of the semester. But hope you guys have